what temperature after cardiac arrest. And we have 4 keynote presenters without slides, but they will answer our question. Chiara Robba, Claudio Sandroni, Nolan, and Markus Skrifvars. So let's start understanding which is your behavior today, because I think we changed our mind on temperature management many times in the last 20 years. We're skipping let's say, normothermia, a temperature higher than 36 degrees, below 37.7. Only a couple of you, okay. Who still keep the patient very with a reduced temperature, let's say 32, 34 degrees. Very low temperature. I don't see them. Oh, okay, perfect. Okay, so there are diversity in the group. Who is controlling only fever? If a patient experiences fever, it doesn't take care about other temperature management. Only, okay, so many of you probably, what is fever for you, she said? Internal temperature, okay.
I think you can use a microphone if you press the button. Can you like to try?
Let's try.
I think the red one.
Let's try. Okay, perfect. So, as far as we understood, there is no, let's say, common behavior. Many of you didn't answer, or you don't manage cardiac arrest of patient, or you don't have clear idea, and I hope that we will try to clarify the idea. I would like to ask to the panel, because I think we have some expert on the topic, to review what did happen in the last few years, because I think I was in this Congress in 2002. I was a little bit younger than today, and 2 papers have been presented at that time on hypothermia. And the people in the Congress were really excited at that time, and the guidance took a little bit of time for changing, but at the end, the behavior outside the hospital did change. I don't know, Claudio, do you want to start about which experience did we have in the last years, starting since 2002?
2002, yeah, with the HACA trial. Well, it's incredible. It was 20 years ago, 21 exactly. It was published in March, by the way, so exactly 21. That was the first trial. Actually, there were 2 trials, but one was a quasi-randomized trial, very small. The HACA trial was larger, but relatively small for our standards, considering it was published in New England Journal of Medicine, and it demonstrated that the use of targeted temperature control, 32 to 34 degrees versus normothermia, quote-unquote normothermia, improved survival with good neurological outcome.
No. Jerry, look at that trial from your eyes today. I think it's easy today to look back and say we made errors and the trial wasn't so good as we thought at that time, because also the research was a little bit different at the early years of this century. What can you say about the impact that the trial had and why we are changing our mind looking at the flows of the trial?
So I guess it's a time to apologise, because if you look at the ill-core scientific statement that we published, I think in 2003, so less than a year after those 2 trials were published, we made fairly strong recommendations at that stage to cool post-cardiac arrest patients down to a temperature of 33 for 24 hours. And very specifically, we made a strong recommendation for post-shockable rhythms, because that was those were the patients that were included in HACA and Steve Bernard's trial. In fact, HACA actually did include about 10 in-hospital cardiac arrest, which not everybody realises, but they did have some in-hospital ones. And then but we also said that basically we left the door open for cooling patients with other rhythms. And I think at the time, they were randomised controlled trials. We were very impressed by those. Times have changed quite dramatically, and I think Nicholas Nielsen in particular and his team started to challenge the potential bias of those trials for a whole variety of reasons. one of the best ones would be, obviously, it's impossible to blind those trials, and there was no protocolized approach to withdrawal of life-sustaining therapy, for example. So that's just one example of potential weakness of those studies. And so I think the introduction then, of course, of TTM1 and then TTM2 is what's really led us to change our views. TTM1 comparing 33 against 36, no difference in mortality or functional outcome. And then, of course, TTM2 most recently, 33 against fever control, again, no difference. I'll pause there because I'm conscious of your...
Yeah, I think we can go in deeper detail of the other trial afterwards, but I think the effect of the trial at that time has been huge, and probably most of the unit did change their way they are managing cardiac arrest patients, thinking about hypothermia, and still some colleagues keeps this way of treating the patient. I can go ahead, but I would like to have questions from you. You have microphone. We can discuss, ask questions. It's an open panel, so we don't have any agenda, and we can build up the agenda together. Please. Okay. Could you introduce yourself and ask a question?
Yes, I'm Pirkka Pekkanen from Helsinki, Finland. When we are talking about cardiac arrest here, are we talking about ventricular fibrillation or all kinds of cardiac arrest?
As Jerry said, there are some differences. We are talking about the protection of a cerebral effect of a cardiac arrest. So for all the rhythm, we are thinking about protecting the brain after the cardiac arrest. Then we have a lot of subtle differences. And I don't know if, Markus, do you want to comment on it?
You mean on the different etiologies for the cardiac arrest? I mean, it's a relevant question. VF cardiac arrest, if they arrive in the ICU, 60-70% of them will survive. A PEA cardiac arrest, 15-20% will survive, and an asystole, 10% will survive, or even less, 5 to 10%. So it's, of course, very tricky with regards to powering a trial, taking into account the relative effect for an intervention in groups who are so incredibly different. But of course, the relevant thing is that it's the brain that we are trying to protect. And based on that, if it works in VF cardiac arrests, then probably it should work in asystole and PEA as well.
Yeah, I think my idea. Now, if you want to comment, you're looking. Do you want to comment again?
Probably it was a provoking question regarding the Hyperon trial.
Well, yeah. Still, just about the title of this talk, it's cardiac arrest and temperature control. And when we did actual temperature control, we did it only for shockable rhythms. But now, when you asked for our clinical practice, you ask about the cardiac arrest, how we treat them. Do we do? At the moment. For me, it's like if there is fever in a cardiac arrest patient with shockable rhythm, then I think I go with the previous set that I insert a cooling catheter, and then I will cool the patient. But for asystole or PEA, that's a bit more tricky. Why should I start it now when it has been shown that cooling the patient doesn't work even for the better patient with the shockable rhythm? So, well, this is just discussion.
I have a comment I will ask Chiara to answer, because I think we are starting to define the topic. We want to protect the brain, and VRS could be by different origin, as Markus said. Let's return back to the pathophysiology and why we did use hypothermia, because I think if we need to return back to temperature control, basic of temperature control, and then we can apply the result of a trial, and we can think about a common pathway for the patient with a cardiac arrest, generally speaking, for giving some advice to the clinician, because I think when you have a patient there, you try to save him or her as much as you can, and the cause is important, and you treat the cause if it's possible. Otherwise, you need to protect the patient. And so, Chiara, would you like to return back to physiology? Why we did cool the patient?
I think that physiology starts with observing something, And if you read the books of the wars, you might remember that the soldiers who were harmed and who were more closer to the fire, they used to die more than the others. So that's why the concept of temperature has been started. Hypothermia itself is protective for the brain. It reduces the metabolism, it reduces the intracranial pressure, and this, we know it from experimental studies. For sure, it depends on the velocity on which you give the hypothermia. We know it for cardiac arrest, and we know it also for brain injury in general. But hypothermia in the experimental settings is not the same as in clinical practice, because it's true that it is beneficial for the brain, it has some good effects for the cerebral metabolism, but we also know that it has a number of side effects. It's not that easy to achieve hypothermia. Sometimes it is expensive to achieve hypothermia. Not all the centers have the devices to do it. And you also have to consider the whole person. For example, in another context for the management of intracranial pressure, we know from experimental studies that hypothermia reduces ICP. So we started to use it many years ago. But we had two randomized control trials. One is many, but the major ones are the POLAR study, that is the most recent, prophylactic hypothermia versus normothermia, no difference in outcome. And another study which compared different strategies of ICP control and hypothermia, and the group with hypothermia who had more harm. And the reason is that you have to consider the effect on the systemic components. And I think also for cardiac arrest patients, you have to think about it. Potentially, just to answer your question, I think that potentially an injured brain is injured regardless of the initial rhythm. But it's also true that this is the point probably of discussion and future research, probably, because in 2019 it was published the Hyperion study, which is a study with a reasonable number of patients, and gave a signal that there might be a benefit in the group of non-shockable. And maybe also in hospital, there was quite 1/3 of the patients were in hospital, cardiac arrest. So guidelines are quite clear in terms of general targets, but then we have to go deep in the subgroups, maybe.
I think I have a question for all of you. I think that we have a sound pathophysiological background for doing things, because in the lab we have plenty of demonstration. And I think one of the maneuver of therapy that have a huge amount of demonstration in the last 50 years. We have so much demonstration. Did we are lost in translation of this information to the bedside? The trial we designed were targeting to certain population, as you alluded to. At the end of the day, I would like to think about a strategy that could be applied to a problem. The problem is anoxic brain injury. And so, do we need to think other way of testing the efficacy, like platform trials in which we can enroll different causes, evaluate them, and decide if we can go ahead with a group or another group, or is too, let's say, difficult to do it today. Another trial in which we want to cover all the aspects of cardiac arrest, and not talking about out of hospital, shockable rhythm, in hospital, not shockable rhythm, and so on. So I think we make the trial complex because we selected for the trial, for having, let's say, a cohort very similar. We selected the population, but at the end we didn't answer to the question of our colleague. I don't know, what do you think? Which is the best way for solving this conundrum of not having the possibility to bring to the bedside something that is useful in the lab?
If I can give a partial response to your complex question concerning the experimental evidence, there is strong, as you say, experimental evidence that hypothermia, even if performed after cardiac arrest and not before arrest, as we do every day, in the operating room actually works. So it's a recent systematic review of several experimental papers show that it works. The problem is in that systematic review, the maximal time to reach the target temperature was less than 1 hour. So the median time of cooling was 11 degrees per hour. This is far, far away to the speed of cooling that we reach in clinical studies and in clinical reality. While in trials, we generally reach the target temperature in 6-8 hours. And this was the main issue for translating experimental evidence into clinical evidence. So one way to go possibly will be to cool patients probably earlier and faster. I don't know.
Markus, do you have any other idea on it?
No, I completely agree with that point, that that's the main problem with the animal studies, that it's so quick to get the animal cooled. But I mean, the Haka trial, in that trial, it took 8 hours before the patient was at target temperature. So it's not, if the effect was real in the Haka trial, it was not hampered by this quite long delay until achieving target temperature. And of course, ultra-fast cooling in the ambulance has been tested with cold fluids, even intra-arrest cooling with cold fluids, and it appears that they have too many side effects. So I think probably we should discuss with the industry, how can we cool a patient non-invasively already during cardiac arrest without the side effects of 2 liters of cold fluid? And then consider, for example, even a longer cooling than the 24 hours, perhaps 48 hours or even 72 hours. And the other thing, I think, is sample size. What's a realistic effect in a very complex patient who's had a cardiac arrest? There's a systematic review. Anders Åhneman is the first author, which says that the evidence today sort of can exclude an effect larger than 3-4%. But I mean, 3-4% would be a number needed to treat of 33 or 25, which could well be a good effect if you have a young asystolic cardiac arrest patient from a hypoxic event, for example. But to show that in a trial, you would need a very large trial, 20,000 patients at least.
I was wondering if someone of you has never tried, or of you has ever tried the pharyngeal or nasal or local methods of cooling.
And I would like to finish with
because it was
with Jerry, and then we will go to local
that
cooling.
Was the exact comment I was going to make, because that follows on from Markus's comment. So the one intervention that is not doesn't appear to be harmful intra-arrest to start that cooling process is intranasal cooling. And of course, there's been at least 2 studies on that, the Prince and Princess trials. The interesting thing about those is, whilst the sort of primary outcome was not statistically different in either of those trials, they've obviously then gone on and done various sub-analyses. And it is interesting, there's quite a strong signal in the shockable rhythm groups. And I know Fabio and his colleagues have published that work, so it's worth looking at that. As far as I remember, in the trials, they were able to get the temperature down, I think, about 1 degree lower at the time of admission in the intranasal cooled group versus the the group that were then cooled after hospital admission. So there is an interesting signal that might get around addressing this problem of the difference between the animal studies, which, as Claudio said, will hit target within an hour, as you've said, versus the much longer times. And by the way, these times of 5 hours plus that have been mentioned are consistent across nearly all randomized trials and all observational trials where that data has been recorded. So you hear people saying, well, in my institution, we always get the temperature down way before that. I've not seen any evidence of that whatsoever. So we have got a real problem in getting, if this works, and it undoubtedly works if you can get in fast enough based on that basic science, but it's just impossible with the technology we've got at the moment to get that temperature down fast enough to the target temperature in persons as opposed to mice and dogs.
Any question? Please, and then, please. No, go ahead.
Roughly 20 years ago, there was a study on mice when they used the H2S for quickly having a hypothermia-like state, which was fully reversible. And now this agent is also possible not only to inhale, but only to put it in IV. What do you think about using some pharmacology to quickly reach the temperature goal?
This is really fascinating indeed. Well, this is suspended animation inducing a lethargic status, and this is the subject of a lot of research, especially in view of the interplanetary missions going to Mars, for instance, and beyond. Yeah, there is research about that. The problem is that inducing, personally, I don't perform experimental research, but the problem is that I'm not sure that we can induce a status of suspended animation in humans, while we can do that easily in rats and any animals. To give you a picture on how different it is, for instance, we know that the bears develop a lethargic state in winter, and so they remain in a sort of comatose state, still, they don't move, they don't pee completely for months, but at the end of the lethargic state, they don't have any muscle wasting. So let's compare that with patients in the ICU. It's completely different, you know? If you don't have diuresis, they're gonna die, probably. But bears don't pee for months, and they're not gonna die. So, they are not so different. Right? So, I'm not sure if this is fascinating, but I'm not sure if there's going to be transferring reality anytime soon.
Please.
Hi, I'm Tiffany. I'm a nurse in the U.S., and I have more of a question on the practical application. Once the change switched to 36 degrees, what I've noticed in my practice and my colleagues, and I think there's some new research, is that at 36, patients tend to shiver a lot more, and so we're actually giving way more medications to counteract the shivering versus at 30. I'm sorry, I don't know why this keeps cutting out.
No, it's working.
And so I'm just curious if you can speak to that and any observations or thoughts on that.
I don't know, Markus, Jerry, Chiara.
We were talking about this at lunchtime, funnily enough, after our demonstration. I'm aware that a lot of people say that you get more shivering at 36. I'm unaware of any high certainty data to prove that, and if I'm right, Markus will back me up. I think it was reported in TTM2, and I don't think the shivering rates were any different. So where we've got high quality data, it suggests it's not different. It is certainly true that it's not less, and of course some people thought that if they used 36 degrees, they would have less problem with shivering. I think it's probably the same, and that certainly would reflect our experience in my hospital.
What's your suggested therapy for shivering?
So it's not a massive problem. So we do use 36. So like you, we've switched, and we haven't yet switched. We'll perhaps come on to the discussion, but we haven't yet switched to so-called normothermia, or you could argue 36 is normothermia, but we target 36. And we routinely use propofol, generally remifentanil now. I don't find it's a major problem, shivering. If it's a major problem, I mean, one can use, obviously, muscle relaxants to solve that. There's all sorts of other drugs that have been suggested that I don't think are actually that helpful. But it's not a massive problem in my experience.
Any question? In the meantime, I will ask them. Where? Okay, please, go ahead.
Hello, Aaron Blandino from Madrid, Spain. Since about a decade ago, we are in intensive care. We are talking about precision and tailored medicine. And I have some worries because TTM1, TTM2 looks like the same trial in different years. TTM3 is underway or planned to be underway, no? But is the design will be the same? We are expecting to have different results. This is any other change to be suggested. I'm saying this because there is some data, observational of course, that when we choose the temperature of the patient depending on the severity, there could be some benefit. I mean, more cooling for most severe patients, like with choosing with the PCAC score.
So, you know, it's not really TTM3, because otherwise Markus gets upset. It's step care, which is a different type of trial, and the targets of temperature is not anymore the three arms of randomization, so three different questions. One is about the target of arterial blood pressure, one is about the sedation, and one is about the use of feedback methods for assessment of the temperature, but not anymore the difference between two targets of temperature.
The point that you raised strangulations, asthma attacks, pulmonary embolisms or suffocation, which of course are the patients that really get horrible brain edema. They are the ones who end up as organ donors, for example, and they have never been included in any trial. So you're perfectly right, TTM1 and TTM2 had very good results, and that was probably perfect group to study hypothermia in a hypoxic cardiac arrest where brain edema is the major problem. I think that's not the major problem in a VF cardiac arrest with fairly short delays. The other thing that you bring up, which is also very relevant, how can we tailor treatment? I think the problem is that when the patient arrives in the ICU or in the ED, it's quite hard. We don't have any good biomarker about this patient is going to develop brain injury. We, of course, have delayed to return of spontaneous circulation that can give you something. We have the complexity of the patient overall. But apart from that, it's very hard to know on admission, is this patient gonna develop really bad brain injury?
Biomarkers are not so informative at the entry of a patient. We don't have CT scan of all the patient. In some causes, we have CT scan, and we can also calculate a little bit of brain edema on the CT scan. And the enrichment of a population or the in which brain edema is the problem, because at the end you use a therapy target to reduce brain edema and the cascade after cardiac arrest to all the patient, even to the patient without this cascade has been alluded before. So probably I think the group you are part of, the panel, needs to think about to promoting some research in this direction. Otherwise, we will still remain connected to cardiac arrest.
Studies that have been published, one from Japan and one from the Pittsburgh group, and both of those kind of come up with the same suggestion, and that is if you take out those with potentially very mild hypoxic ischemic brain injury and take out those with very severe hypoxic ischemic brain injury, in other words, both of those where the intervention may not impact outcome, and look at that middle group of moderate injury, then there seems to be an association there with the use of 33, so hypothermic temperature control and better outcome. But it's all observational work. Now, whether we've got sufficiently good predictors at a very early stage of who is likely to have mild, moderate and severe hypoxic ischemic brain injury, we need to do further research on. But if we did that, we could then potentially select out that middle group and try the, and use the intervention in that group to see if it does make a difference in a prospective trial.
Please.
Possibly one way to stratify prognosis score, for instance.
Yeah, but for having score, we need to have something strong that could anticipate what has been alluded by your colleagues. So we Please.
Thank you. Regarding brain edema, can you tell me which patient will profit from treating brain edema? Do you treat brain edema?
Chiara, please.
The truth is that we don't really treat brain edema in a targeted way, and the reason is that in reality, we don't do anything except for the sedation, which is a part of the general management. But there are no protocol in the cardiac arrest which suggest osmotic therapy or other type of strategies that are used in brain-injured patients. Here you open a very big window because the concept of the neuromonitoring in these patients is gaining interest. There is and episodes of desaturation. I don't think it should be probably always a routine, not in all cases, but I think that, again, creating some phenotypes of patients who can benefit from this, it can be a possibility. The other option that we have is using the non-invasive method to assess ICP or oxygenation.
So when we do a CT scan 24 hours after resuscitation and we see a brain edema, you just let it be. It's a brain edema, we don't treat it because there's no evidence.
We don't have in our practice, we have put some ICP bolt in some cases, but it's not routine yet. We personally use echo, we use NIRS, and we use transcranial Doppler. I have just one, it's a provoking comment on this. I would use intracranial pressure
on what you said, returning back to what they said, because we have different patients. We have patients with a low damage, so the cytotoxic edema will be very low, small. Whatever you do. there is an intermediate situation in which, returning back to the selection of a patient, in which brain edema, the cytotoxic brain edema, could be, let's say, solved with some strategies. And also intracranial pressure is an effect of brain edema. You are not treating brain edema. You are not treating brain edema. Action of temperature. But the illusion of a 3 different category of patient could be applied also to brain edema. And probably the middle of the category, not a small quantity of brain edema, not a huge amount of brain edema we cannot save, but the problem of energetics of the brain impaired by the low flow, in this middle-sized situation, probably we can make a change, blunting the response with what we want. And we can control some effect like high intracranial pressure, but in this setting is not so huge. And also the situation possible.
Yeah. If I can add something
Please.
to your, okay. Apart from regarding brain edema, just a quick comment. You were mentioning patients with brain edema after cardiac arrest on day 1. Indeed, this may happen, especially with a very prolonged cardiac arrest. Patient has been resuscitated 1 hour or so, or for with ECPR. But there is evidence that brain on brain CT. This is important. The main time for death due to brain edema after cardiac arrest, brain death, is 3 days on a systematic review. So if we have to reduce or treat brain edema with treatments including hypothermia, this needs to be considered for the length of the treatment we are going to plan, not just 24 hours. Probably it's too short.
Please.
Balázs Hauser from Budapest, Hungary. There are some ultra-rapid MRI sequences for diagnosing a stroke in a very, very early phase, like within 1 hour after onset of symptoms. Why don't we implement this in the early
Excellent idea for prognostic purposes, as has been made in a Korean study. They tried an ultra-early MRI. And the first, like if I remember well, 4-5 hours after cardiac arrest. And apparently it works for prognostic purposes. So it may be a way to stratify patients. I think it's a very good idea.
We have 7 minutes. For the future, which are the advice? We saw there are diversity here about the way we manage the temperature. So we have guidance, Jerry. Could we suggest, let's say, some boundaries in which we can move in waiting new evidence?
So what the current position, I mean, I can tell you what the current position is as far as the guidelines are concerned, and that is that we are recommending the use of normothermic the evidence varies depending on whether it's out of hospital, in hospital, etc. But that's the very broad guideline we're working to at the moment. However, if you look at both the ILCOR, the International Liaison Committee on Resuscitation treatment recommendations, and ERC and ISICEM guidelines, the second point is that there may be subpopulations of patients that may benefit from hypothermic temperature control at 33 degrees. The problem is, and this comes back to the basically saying the research needs to be done. So we haven't completely shut the door on hypothermic temperature control, but at the moment, based on the science, we're advocating normothermic control. But notice I've used the word temperature control. That's not doing nothing. And remember, even in the control arm of TTM2, for normothermic control, half of those patients required devices to do that. So it's still an act.
Markus, which kind of device do you advise today? Because we discuss about local devices or global devices. What do you advise today?
So our practice has changed a little bit more, focusing now on non-invasive devices, because if you don't put it in right away...
Not intravascular. So,
no,
okay.
Because if you don't put it in right away, then it's much, much easier to start it in the middle of the night when the ICU physician is sleeping. We have some observational data actually showing that high fever is not that common in these patients. So in most patients, you'll probably be fine with as shown in TTM2, with just giving a bit of didn't have many patients. This has never been published, but I know this, that they didn't have many patients who were 39, even though that's what everybody thought, but that was not the case. So I think that the whole concept of treating fever in the ICU is something. And for me, I can say that, yes, in my ICU, I want all my patients to be 37.5 or 37. That's fine, I can say that. But it's a question of what are you going to do about it? Are you going to put every patient on a device? And to do that, I think we need must study these devices and see whether they really work or not.
Claudio, any pharmacological support of the discussion we have, brain edema and so on, during
treatment as paracetamol that Markus mentioned, and I can confirm that about a half of our patients actually need a device. The device we use is a cooling blanket. All the other patients just need to be uncovered and used and we sedate these patients less, and this will probably allow an earlier prognostication. Because if you have to prognosticate, and in order also to assess your patients, you need to make a sedation stop every day, and if you don't sedate them, it's much, much easier.
Chiara, how long do you suggest to sedate the patient?
To keep the temperature, as mentioned, the guidelines say 70. From the CT, from the risk of brain edema, and from the need to maintain the temperature. I just wanted to add that my experience is more like Markus' one. In the first 72 hours, it's not that common in my experience that patients have so high fever. They develop it eventually later when they start to have infections, VAP, etc. And actually, in many cases, they arrive from the extra-hospital area or from coronarography, etc., who are more hypothermic than normothermic. So, in case we start with the drugs, not always they work, I have to say that. But we have abandoned the intravascular methods for one simple reason. Not completely abandoned, but we try to avoid it, that we are much more careful about the fluid balance, and the risk of giving cold fluid is that you give the fluids to put the temperature down, but at the end of the day you have given them a very positive balance, which is not good for these patients.
It's 5:50, so we are on time, because Fabio said to me, if you go ahead, we have to pay the room, so we will close the room in a couple of seconds. If you have any burning question, otherwise I think we can keep tuned and to see. Please, burning question. Why you wake up now? Because you are hypothermic? No, we can hear you if you want. You can speak, we can hear you. We can hear you.
I can tell you what I do. So we don't, in our hospital, we don't vary. So we just use the same protocol regardless of the etiology, because I don't think, whilst in theory we've heard all the reasons why you might target different temperatures to different people, the evidence just isn't there, and it causes just chaos. So it's much easier to just have a blanket rule across the whole lot, and everybody knows what they're going to do, and they get on and do it. If you, as soon as you start sort of separating out all these different groups, it's going to make it a lot more complicated. Maybe that's the simplistic approach, but...
Thank you very much indeed for your attention, and have a nice evening.